anaesthetic registrar in Northwest London. And I'm joined today by Andy McGrath, who will introduce himself in a minute. Thank you everyone for joining us this evening, and thank you to Nat for organising it all. And we are both anaesthetists in training and want to just give a little bit of information to you guys and hopefully persuade you guys to join a career in anaesthetics, really. As we say, I'm Johnny and that's Andy, and we'll both do a quick introduction and a bit more information about us in a minute. So today's session really is about trying to give you guys what information you need to give you a little bit of a flavour of what a career in anaesthetics is like. And then Andy will go on to talk about how to get into a career in anaesthetics. Of course, questions are more than welcome, and we encourage you to ask questions. I think what we'll do is any burning questions, then please message them. But at the end, we're going to have a Q&A session. Hopefully, we'll get through our content nice and quickly, so then we can take as many questions as possible. Natalie is going to provide a feedback form or a link, and so please fill that in to ensure that we can continue to progress and make each session as good as possible. So without further ado, this is what we're going to do. I'm going to first touch base, talk a tiny bit about me. That's the boring bit. We're then going to go on to cover what an anaesthetist is and what roles they have and what's a normal day in anaesthetics. And then Andy will go and talk more about the practical implications about training, how to get into anaesthesia, and then the training program. So my journey, well, I grew up down in Bude in Cornwall, had a lovely time down there, and then went to university in Southampton, so staying pretty south. And whilst at uni, I did my medical degree, and then I did an integrated master's. And during this time, I got quite interested in surgery. And I thought, okay, well, maybe I will do surgery, maybe maths facts. I then moved up to Northwest London, and I started working firstly at St Mary's Hospital, which for some of you may know, which is a major trauma centre in central London. And I saw a lot of action from the surgeons, but I also saw what anaesthetists do. And I thought, oh, that is quite interesting. And I also got chatting to a few consultants, and they said, oh, have you thought about anaesthesia? It's a really good specialty. It will probably suit your personality. And I thought, oh, okay, I'll have a go. And so when I was applying for my F2 jobs or ranking what I wanted, I put down intensive care as one of my jobs that I like to do. And I did that intensive care time at Northwick Park, which is also in Northwest London. Whilst doing intensive care, I realised that anaesthetists, by and large, are pretty relaxed people. They are happy to have a good time. Compared to surgeons who are always running around, they're stressed, they're running from clinic to theatre to everything. Whereas all the anaesthetists were having a good time, reading their paper, drinking coffee, and life was good. So I thought, yeah, I'll tell you what, I'm going to apply for anaesthetics. But first of all, I travelled for a year, I had a bit of fun, and I encourage everyone to do that. Don't get told that you can't take a step away from your medical career. The more further up your career you go, the more you realise that actually taking a bit of time for yourself is really important. So don't be put off, it won't step you back anywhere in your career. And then I applied for core anaesthetics, starting that in 2018, and now I've just started registrar training this year. And as I say, that's on the Imperials rotation. So what does an anaesthetist do? What is the role of an anaesthetist? Well, if you go on the Royal College of Anaesthetists website, you'll see this quote here by Prof. Ravi Mahajan, who is the Royal College of Anaesthetists president. And apart from saying things like they discuss the type of anaesthetic that you do, they discuss the risks, etc., he's also said what I think is his rather theatrical quote of, "We are there by your side when you need us most. It is what we do, and it is who we are." Well, maybe some of that is very true, but what do we do day in, day out? Well, here's another schematic taken from the Royal College of Anaesthetists. The vast majority of our work is, of course, in theatres. And we are providing largely general anaesthetics to patients undergoing operations. Sometimes that might be a sedation. Sometimes it might be regional anaesthetic, where we're delivering local anaesthetic around nerves. But the majority of our work is in theatre. However, we are the largest single largest UK hospital specialty. And there are a good amount of us. You say we make up 16% of the consultant workforce. And they say here that we are positioned on the borders of medicine, surgery, and foundation skills. And I think the schematic shows that, starting to show actually what we do. We do a lot of different stuff around the hospital. It's not just in theatre. Broadly speaking, anaesthetic consultants can be divided into 3 types. So on the left-hand side, you have general anaesthetists. And as I say, the vast majority of people are general anaesthetists, providing anaesthesia for operations. You can then also subspecialise in intensive care, and you can also subspecialise in pre-hospital care. Pre-hospital care is obviously the smallest out of those specialties. Intensive care, bigger, but obviously the vast majority are general anaesthetists. And when you do your general anaesthetics training, you can do what's called dual CCT, which I'm sure Andy will touch on more. But this means you train as both an anaesthetist and an intensive care doctor, or you can be an anaesthetist and a pre-hospital care doctor. And when you're a grown-up consultant, you'll share your time between these areas. And you can focus on general anaesthetics for, say, 3 days of the week, and intensive care for 1 or 2 days of the week. I'm just going to focus really on the general anaesthetics role, or general anaesthetist kind of role, should I say. So even as pure anaesthetists, just doing anaesthetics, no intensive care, you can see that all of these are different subspecialities of anaesthesia. So you have your larger specialities, such as being a cardiothoracic anaesthetist or an obstetric anaesthetist. But you can also have other specialist interests, such as being a pain medic. You can be interested in perioperative medicine and trying to get typically elder and more complex people with multiple comorbidities, optimizing them for theatre, seeing them in outpatients, working out what risks are involved in operations, and then bringing them all the way through the perioperative pathway. And so this list here is just just to represent the amount of different areas you can get into. And as a grown-up consultant, after you've been a consultant for 10 years, you'll probably find your feet and maybe decide that 1 or 2 days a week you'll do some let's say regional operations for orthopedics, or you might do 1 or 2 airway lists, and everyone will find their feet depending on what you decide to do. Starting off, you don't need to worry about this. You just get a taste and flavour of what you like. There are lots of different societies, and again, these are all the different societies associated with the Royal College of Anaesthetists on their website. And so all of these societies are there to really flourish your interest in any area of anaesthesia, but also to the societies that lead the way in their subspeciality and offer conferences, for example, and events. So now I'm going to talk a little bit about a day in the life of what do we actually do on the ground. So here is what I consider a relatively normal week for me, as I'm a ST3, so as my first year as a registrar in anaesthetics. And I'm currently at Hammersmith Hospital, which I'm doing my subspecialty training in cardiothoracic anaesthesia, which is one of the mandatory modules that everyone in anaesthetics has to do. So you can see that Monday to Wednesday, I'm doing some cardiac and I'm doing some thoracic anaesthesia. One of the best things I think about anaesthetics training is that you will always have a consultant there with you. So you can see Dr. Boynton, Dr. Chris, Dr. Carol. And that is true all the way from your first day in anaesthetics training all the way to your last. And what that really gives you, it gives you one-on-one training doing anaesthetics every single minute. And of course, when you start off, that teaching will be a lot more hands-on, and you work up to get a bit more responsibility and autonomy. But I really think that's one of the best things about anaesthetics training is you do get one-on-one teaching. It's not like a surgical core training job where you're just left on the wards and told to get on with the ward round while the consultant goes, to theatre, and you're expected to know how to perform a lap appendix. It's completely not like that in anaesthetics. You'll then see that so this was a couple of weeks ago, and then over the weekend I was doing some on-calls. And of course, anaesthetics being an acute specialty, there is an on-call element to it. At the bottom, anaesthetists are very keen in education and simulation. And so I have two different teaching things throughout the week. So we've got TOE, which is transesophageal echo teaching, for an hour one day, and then on Wednesday afternoon, the vast majority of that afternoon was teaching. So you can see that it's the vast majority of your weekly schedule is a bit of elective work in theatre, alongside a consultant getting one-on-one teaching, and you'll progress through a range of specialties. You'll get a large amount of formal educational content, and then there'll be the on-call element. So what's my normal day? So to start off with, I leave work about 7 o'clock. I leave home, about 7 o'clock, and get to work at about 7:20. Anaesthetics is normally quite an early starting specialty. I wouldn't worry about that if you're not an early starter. You'll soon get used to it. And you'll find that you're there in the hospital seeing patients before anyone else is there, really. 7:30, you've got change. You go off to see your first patient for the operating list. You do your formal assessment, and then you come down to theatres where you discuss the theatre cases with the surgeons and your consultant. And then by about 8:30, the patient's in the anaesthetic room and you're starting putting them to sleep. And this is a question that I get asked quite often by friends and family more than anyone else. What do you actually do when the patient is asleep? Lots of people think you put them off to sleep and then somehow miraculously they lie there still, they don't wake up, they're not in pain, and then you go off and do the crosswork. Well, I've just had a bit of a brainstorm here, and this is what I kind of keep myself busy doing for that individual patient during every single anaesthetic. So you've got to make sure that they are asleep. Obviously, they're pain-free. They're paralysed if they need to be, so the surgeons can do their operation. We clearly monitor them throughout, and that may be invasive or non-invasive monitoring. You obviously treat any hemodynamic instability, and we've got to obviously monitor for any emergency situation. So if there's any bleeding, we've got to see if they become hemodynamic compromised or are they having anaphylaxis. And then we've got to think about after the operation as well. So we prescribe the drugs, we write up our preoperative assessment from beforehand. So there's a whole raft of things that actually keep us busy. Then when we think about not just for this patient, but what else do we do when the patient's asleep? So we prepare for the next case. Often, depending on what theatre list you're doing, it's rare that you just have one case in that day. If you're in a day case operating list, you may have 5, 6, 7, 8, 9, 10 operations. And therefore, for each of these patients, you need to go and see them, assess them, prepare for them. So there's a whole amount of extra stuff that you do. And it's not very often that you get to sit down and do the Sudoku or read the paper or whatever it is. However, it's a very social specialty. You do get to chat to colleagues. You go into other theatres to offer coffee breaks. And sometimes around revision time, there is a real understanding from the consultants that trainees do need to revise. And students and consultants are very good for letting you do that. So as you can see, it's not unfortunately just sat down at the head end, going to sleep and waiting for the patient to wake up without any intervention. Importantly, this is a frequent occurrence in anaesthetics. By about 9:15, you'll probably get your first your consultant saying, "Oh, it's probably about time you only got some coffee," and you take that invitation and go and have a nice little sit down and have a coffee. And then obviously you come back and they go for their coffee. And about 11:45, you get asked about lunch. So you do get a chance to sit down have a bit of a break. And I think that's why you find most anaesthetists are pretty happy. By about 3:30, the end of the day is coming up. You're working out whether if the surgeons are being too slow or not, and whether you can get to the end of the operating list. And the list will typically finish about 5 o'clock. Of course, there's times where the list will go on after that. It may be aware, if they've got a big operation, if they've got a Whipples or something, then the case will go on longer. And by about 5:30, I'm at home. That's a typical day. As I said, we do a large element of on-call work, which I find very exciting. It allows you to go out and have a bit more autonomy and work on emergency patients. So what we actually do on a day-to-day basis on call very much depends on, firstly, the hospital, but also the grade of trainee you are. So I'll go through the grades first of all. As the anaesthetic SHO, in most hospitals, you'll be involved in the CPOD list, which is the emergency operating list. And as the SHO, you will get told about a case from the surgeons that they want to do, maybe a laparoscopic appendicectomy. And you'll go off and you'll pre-assess that patient, and then you'll come back and you'll discuss it with your colleagues, and then you'll do that case together. You also go off and see critically unwell patients. You may be attending cardiac arrests, working in a bigger team. These could be anywhere from A&E up into the wards. Cannula calls are the bane of the most junior anaesthetist's life. You'll get called to do difficult cannulae, but in the end it becomes quite satisfying when you can get in the difficult cannula, and you know that after you've done your time as a junior anaesthetist, sooner or later you'll be the registrar and won't be going to all of these calls. There's also reviews and recovery for patients who have had their anaesthetic, and every now and then you get pain reviews for people with epidurals or difficult patients to manage. So then you're a registrar, and what do? Well, you do pretty much the same stuff as the SHO does, but you're supporting your SHO. You're taking a much more of a leadership role in the CPOD emergency list, but you're still also going to the cardiac arrest calls and managing the critically unwell patients. Some hospitals you're in, you work alongside ITU very closely, and you're stabilizing patients before taking them to intensive care. And then as a consultant on call, well, you're doing a bit of everything. You may, at quiet times, you may be in your office catching up with paperwork, but the vast majority of times they're assessing and seeing difficult cases. They're offering support to the registrars and the SHOs, and they're kind of being a general manager, per se, of the whole theatre environment. It's also dependent, as I say, on which hospital you're at, and each hospital will have their own nuance about what speciality they treat. And so I've just picked a few different things here for some of the London hospitals. So if you work at Charing Cross, you'll get a lot of thrombectomy calls as they're the regional centre. If you work at Hammersmith, you'll get a lot of heart attack centre calls, so patients with out-of-hospital cardiac arrest coming in for with a STEMI, and they need a coronary angiogram and stenting. Some patients, as the anaesthetist, you are looking after all the most unwell paediatric patients, and you're stabilising those kids, waiting for specialist retrieval teams to come and pick them up. And of course, you have trauma calls, renal transplants, all these kind of these far more specialist areas which happen at different hospitals. But as a trainee, you will rotate through all those hospitals, and you get a real experience to work out where you want to go when you're later, or when you're older. We of course do night shifts, and it's a real balance between some hospitals. You'll get a lot more time in the on-call room having a sleep, which is great. And some other times you'll be doing a bit of everything else. So it might be a renal transplant in the middle of the night, which keeps you up from 12 till 6 in the morning, and you don't really get to see the on-call room. But it's a nice balance, and that will vary between hospital and hospital. I'm just going to touch on intensive care. As part of everyone's training in anaesthetics, you have to do some time in intensive care, and I'm sure Andy will touch on that in a minute. And what do you do? Well, normally you obviously do what you normally do on intensive care. So you're there on partaking in ward rounds, you're reviewing unstable patients, you're updating families, you're doing jobs like inserting central lines. But as the anaesthetist, it's quite nice being on intensive care because you are airway skilled. And therefore, even though there may be medical or surgical trainees more senior to you, if you have skills of how to manage a critically unwell patient and their airway, then actually you get given a good amount of responsibility. So that's where I believe I'm going to end my talk, and I'm going to stop sharing my screen so Andy can come and take over. And I will catch up with you all for questions.
Hello, everybody. Let me just maximize my PowerPoint slides and go to the beginning. Hang on. Thank you very much, Johnny, for that introduction and a bit about what we do on a day-to-day basis. So I'm going to talk about my bit now. So a bit about my background, and then a bit about how to get into anaesthesia, something about the application process, although that's all changing at the moment, and a bit about the training program as well. So a bit about my background, my journey. I grew up in West London, didn't think I wanted to do medicine at school, so applied for a science degree, have a biochemistry degree from the University of Oxford, but thinking about it a bit more, really like the idea of medicine, so applied for a graduate entry medicine at Imperial College in London. I then completed foundation in the North East Thames Deanery, so spent time out in Essex and Romford and Chelmsford. And at that time, although I had thought about anaesthetics and had done a medical student specialty choice module actually at Northwick Park in intensive care, I thought I wanted to be a medic, but quite like the acute specialties. So I ended up getting an acute care common STEM acute medicine job in the Oxford Deanery. I was at Wexham Park Hospital just outside London in Slough for 2 years. But when I started the anaesthetic part of the ACCS pathway, it became very clear to me, for all the reasons that Johnny's just mentioned, that anaesthetics was what I really wanted to do. So I reapplied for a core training post and got a core training post at the Imperial School in London. And so I've since been at Charing Cross in West London, St Mary's, Northwick Park, and I'm currently a clinical fellow at Charing Cross Hospital. So I've done just over 3.5 years of anaesthesia and intensive care medicine. So a bit about how to get into anaesthesia. The application process has changed somewhat since I did it 3 years ago. The routes into anaesthesia remain the same. So there's 2 ways you can get in, or 2 different career pathways for the initial bit. So either core anaesthetics or the acute care common STEM ACCS anaesthetics route. As the 2021 curriculum, which is coming into force when you guys take up jobs, is only quite a recent thing. They haven't got a very nice pre-formatted diagram that I could steal off the internet to put on here. So I thought it was easiest for me to draw it out. But so it used to be that core training was 2 years. It's now going to be 3. So core training years 1 to 3, so CT1, CT3. And the ACCS, again, has been prolonged from 3 years to 4 years. So it's now CT1, CT2A, CT2B, and CT3. And that forms the core or stage 1 part of the training. At the end of that, once you've got all the competencies for that and you've passed the first of the Royal College exams, the primary FRCA, you're then eligible to apply for registrar posts that take you through to consultant. That will bring you into stage 2, which is ST4, specialist training year 4 and 5. To progress to the next years, you have to pass the final fellowship of the Royal College of Anaesthetists exams, That takes you into the last stage of training, which is ST6 and 7. And then you get to the certificate of completion of training, which is it makes you eligible for application to consultant posts. I'll talk a bit more about the training pathway later, and there's a separate section on that. So thinking about applying for anaesthetics, you have to think about whether you want to do core anaesthetics or ACCS. So what are the differences between the two? As I mentioned, core training what is now 3 years. It allows you to cover the core competencies in anaesthesia and currently includes 3 to 6 months of intensive care medicine. ACCS anaesthetics is now 4 years. In CT1 of ACCS, you do 6 months each of acute medicine and 6 months of emergency medicine. In CT2A, you do 6 months of intensive care medicine and 6 months of anaesthetics. The CT2B year is the equivalent to the anaesthetics CT2 year, and then you will now have to complete an extra CT3 year. So during stage 1 training, the first goal you have as an SHR, as a core trainee, is to try and achieve the initial assessment of competence, which is this thing called the IAC. And that's basically a passport to start looking after patients under anaesthesia without direct supervision from a consultant. As Johnny mentioned, throughout our career as anaesthetists or trainee anaesthetists, you're pretty much almost always supervised by a consultant, but this gives you the ability to anaesthetize fit well patients for simple things without direct supervision. By the end of stage 1, it's expected you will have also achieved the initial assessment of competence in obstetric anaesthesia, which is similar to the IAC, except it's for obstetric anaesthesia competencies. So things like the ability to site an epidural for a woman in labour, provide anaesthesia for a cesarean section, and again is a passport to being put on the obstetric on call rota without direct supervision from a consultant, and able to perform those duties independently. At the end of stage 1 training, you should have achieved the core level training certificate, which is the sign off for all the competencies you need to have done by that stage, and passed the first exam as part of the Fellowship of the Royal College of Anaesthetists, the primary. This, however, at the moment has changed because of current COVID requirements, not requirements, because of restrictions, and the fact that lots of exams were cancelled. So they've changed the fact that you need to pass the primary to progress to the next stage. But I suspect that's likely to go back once you guys get jobs. So this is just a picture of the initial assessment of competence. This is actually a bit old in that now it's all documented on the lifelong learning platform, which is the Royal College's e-portfolio. But just so you get an idea of what it involves, it just requires you to complete specific assessments for the basics of anaesthesia. So, for instance, preoperative assessment of a patient, basic airway management, and the management of common emergencies within anaesthesia. And similarly, this is the initial assessment of competence in obstetric anaesthesia. And as you can see on the right, the supervised learning events, the ACACS, DOPS, and TBEs required to get signed off for that are things to do with obstetric anaesthesia. So being able to site and top up an epidural, understanding something about the physiology of pregnancy, all those sort of things. So just back to the question about core versus ACCS. So just a bit about the benefits and downsides of ACCS anaesthetics. So the downsides are that the curriculum in the ACCS curriculum is huge. There are, I think, 8 major presentations, 24 minor presentations, and I think about 30 procedures that you need to get signed off one by one in order to progress. It is quite laborious, having been through it as an acute medicine trainee. It prolongs your time until you're just doing what you want to do. And also it prolongs your time until the completion of training to a consultant. So if you want to do anaesthetics, there is an argument for just going straight for anaesthetics. But having been through it, it does give you excellent exposure to other acute specialties. There's something to be said about working in A&E if you haven't as a foundation doctor, and understanding how different departments in the hospital work and their different pressures and strains. I think that appreciation of that does help my day-to-day work now. It gives you more points when it comes to applying for registrar jobs at ST4, because there's extra points on the self-assessment score, which forms part of your overall mark. And it gives you a bit more time to complete exams, get through the FRCA exams, build your CV towards registrar jobs, and maybe you'll have time to do other exams as well, for instance, the MRCP. So there is a benefit from that as well. So when thinking about applying for anaesthetics, the Anaesthetic National Recruitment Office, or ANRO, website should be your first port of call. It contains all the information that you need to know for applying for anaesthetics or ACCS anaesthetics. And on there's two documents which you really need to read quite carefully. So there's an applicant guidance document, the one on the right, for this round of anaesthetics CT1 applications for August 2021. And there's also applicant guidance on the multi-specialty recruitment assessment, the MSRA, which is something new to recruitment for anaesthesia at this stage. So I'd advise you reading those carefully. Those should be your Bible. So in terms of timeline for recruitment, I understand there's quite a lot of F2 or post-F2 doctors who are thinking about applying in this current round. If that's the case, I hope you've had a look at the deadlines, because the deadline for application is the beginning of December, so coming up quite soon. The interview window for jobs next year will be the beginning of March, the beginning of April. Initial offers will be made mid-April, and you'll know if you have a job by the end of April. And hopefully by now those that are applying this cycle have used Oriel, which is the NHS recruitment website. Please don't underestimate the amount of time it takes to fill in the application forms. They can be quite arduous. There are lots of things about your previous employment history, all the jobs you've done since the start of foundation. So please do start early and make sure you get it submitted in time for the deadline. So anaesthetics recruitment has changed somewhat since I did 3 years ago. It used to be that you applied with a self-assessment score based on criteria, which I'll show you a bit later, and brought a physical portfolio to the interview to show to provide evidence to support your score. That's no longer the case. So there's no unverified self-scoring. There's no self-scoring at all. This has been replaced by the multi-specialty recruitment assessment. And because of the COVID pandemic, Royal Colleges has been asked to produce a plan A and a plan B for different eventualities. So plan A would be the ideal situation where the COVID pandemic doesn't affect recruitment too significantly. And so for anaesthetics, 15% of the mark will be made up from the MSRA. If there's more applications than there are interview spots, the MSRA will be used for interview shortlisting. But the vast majority of the marks will come from the online interview. So 75% of the marks will come from the online interview. And this will be made up in the Plan A scenario of 2 panel members, which will be consultant anaesthetists, and will last 30 minutes. 10 minutes of that will be portfolio-based questions, so things on teaching, training, audit, quality improvement. There's no need to prevent any evidence. 20 minutes on other things, so commitment to specialty, communication, decision-making, reflective practice, teamwork, working under pressure. And the Plan B scenario is there in the eventuality that the pandemic means that there's less available consultants to interview. And it will be the same sort of setup, except there will be one consultant interviewing. So that's the basic structure of recruitment as it stands. The multi-specialty recruitment assessment is there to assess knowledge at F2 level. It's a generic recruitment tool used for a variety of different specialty recruitment within UK medicine specialty recruitment nowadays. And it has two parts. So a professional dilemma setup, which for those of you who train in the UK should be quite familiar because it's very similar to the situational judgment test. It comprises of 50 questions, and 8 of which will be pilot questions and last about 95 minutes. And then there are clinical problem questions as well, so which consists of 97 questions, 11 pilot questions, and you have 75 minutes to do that. This talk itself is not designed to be a very detailed discussion of the specialty recruitment process, but Medicine Essentials have already done a generic specialty applications process, and it's on YouTube. And I would advise you go and have a look at that because it's got useful information and more detailed information on the MSRA, and a good question and answer session afterwards. But just a few tips. You may as well answer everything. There's no negative marking. You're not going to lose out if you get it wrong, but you might gain if you get it right. And as with all these sort of things, read the questions carefully, but quite often your gut instinct is correct, so go with your instincts. There's more about as I mentioned before, about the MSRA in this document, which is on on the ANRO website. Excuse me. So interviews, some general things. I was involved with the registrar interviews for the last round of applications, which were the first time they did use an online format. They use Microsoft Teams, which is very similar in format to Zoom. But if you're not familiar with it, I advise you download and play with it and get used to it. There's a lot to be said about making sure your setup is good. So make sure that the camera's at a good height, that your video camera's not looking up from you from below. Making sure there's good lighting, you have a light in front of your face, so you can be seen clearly, that there's nothing offensive in the background and there's a pleasant something in the background, and that you're aware of your environment. So the building site across the road isn't going to start making lots of noise mid-interview. Just useful things to think about. And there are useful YouTube videos on the internet for generic interview technique using online videos for online interviews. So I would advise you look at those. You're responsible for your IT. Make sure you have a reliable internet connection and check it. They do allow you to appeal if there's been a technical difficulty, but it's not worth the stress and strain of having to deal with that on the day. And I would say practice, practice, practice. Using online platforms, talking to a computer is very different to talking to someone in person. Do it with your friends, do it with your colleagues. If you can't even use things like Photo Booth, if you have an Apple Mac, to record yourself, so you can see what you do when you're talking. You can listen to turns of phrase that you use, and it's just good useful practice. Practice is everything. Dress code. Make sure you're dressed smartly and professionally, nothing too dazzling, bright, eccentric. So for men, that means a suit and tie, means you're clean shaven. The interview panel are looking for somebody who they think will be a good colleague later in life. So you want to be smart and professional. So a bit about the interview structure. So as we mentioned before, they've said that 10 minutes will be on portfolio questions. So teaching, training, audit, and quality improvement. This is essentially what achievements you have to date. Before, it was quite easy to see what they're after because the self-assessment score made it obvious what they were looking for and what they scored highly. So I'll show you now, but if you Google anaesthetic recruitment self-assessment CT1 2020, you can find the PDF of what the previous round of applications had to use. And I think that's a good structure to think about how you should think about your previous experience and achievements. And then 20 minutes is on other things. So commitment to specialty, communication, decision-making, reflective practice, teamwork, working under pressure. These things are more about what attributes you have and what skills you've developed in your time as a doctor. And you need to think of concrete examples on how to back your answers. So this is the self-assessment criteria for the last round of recruitment. And I think it's a useful framework for thinking about where your achievements are and what things you should try and sell at an interview. I think you guys are at a slight disadvantage in that previously you had to bring a physical portfolio, so it's quite easy to show what you'd achieved. Now you've only got a very small space of time to really sing your praises and sell yourself. So on the self-assessment criteria, there are things about whether you have additional degrees, if you won any prizes and awards, if you've got any other postgraduate medical qualifications, or most people applying for core training won't have done. If you've got any experience in complementary specialties, bits about commitment to specialty. So if you've had any experience in anaesthetics intensive care before, and whether you have done a taster session or a student selected component in medical school, done any courses relevant to anaesthetics, or you've got any exams that might be helpful in a career for anaesthetics. Involvement in clinical governance, audit and quality improvement. Have you been involved in an audit and closed the loop? Have you presented at a national, international conference? Any involvement in research? What extent you've been involved in teaching? Whether you've published anything, presented anything, and whether you have any significant other achievements outside medicine and leadership which might be relevant to a career in anaesthesia. For those of you who aren't applying this round, and for those who are, this self-assessment criteria is very similar to the one they use for registrar applications, and the scoring is barely changed. So if you think about a career in medicine, it's useful to career in anaesthesia. Sorry, it's useful to use this as a framework for building your experience towards applications and getting the maximum marks for applications. So my advice to you would be to go through each section listed there and list your involvement in each and your achievements in each. And it's very important that for that 10 minutes, you're able to sell yourself as best as possible. And that means knowing your portfolio inside out, being able to present what you did and your involvement and sell it as best you can. The other interview questions, so they're primarily based on sort of desirable attributes and skills which are documented in the person specification. And again, this is easily available on the ANRO website, the Anaesthetic National Recruitment Office website. And it's important to make your answers personal and specific to you, which means you're much more likely to score highly. So this is just a screenshot of the personal specification for CT1 entry in 2021. The essential criteria are the bits that they use to long list candidates to make sure that you have a medical degree, you've achieved foundation competencies, that you can speak English, all those sort of things. The selection criteria is split up into essential criteria and desirable criteria. And then, as you can see, are split up into clear qualifications, clinical skills, academic skills, personal skills, probity, and commitment to specialty. This document basically outlines what they're looking for in the ideal candidate and should form the structure of your interview preparation. And then in terms of how they score the interviews, as we mentioned before, the two consultant assessors, each domain, they have 5 marks each. So qualifications and experience, involvement in teaching, audit, quality improvement and research, commitment to specialty, communication, decision-making, reflective practice, team working under pressure. And then at the end, each assessor has 10 marks to give a subjective global assessment of how they think you are as a candidate and how well they think you've done. Overall, the whole interviews out of 100. And as we mentioned before, that makes up 75% of the global mark for application. And then they use that to assign the jobs you've ranked at the end of it. So my other advice would be start preparing early. Don't underestimate the work that's involved, and practice is key. I think self-assessment criteria and personal specification are useful as a guide to what is expected of you. And I know it's difficult, it's easy to say before the interview, and it's probably difficult to do, but smile and be enthusiastic. At the end of the day, the panel are trying to pick potential colleagues that they want to work with, and being sort of friendly and affable is part of the game, and will get you a long way. This presentation isn't meant to be a detailed guide on how to prepare for interviews, but I think that just gives you a background structure of the things to think about. There are plenty of online interview courses and that sort of thing, which give you ideas of how to structure specific answers. So a bit about the training program. Just back to my diagram. This is the basic outline. So under the new 2021 curriculum, which is coming into effect when you guys start work, there's 3 stages: stage 1, stage 2, and stage 3, which is roughly equivalent to the old system, where stage 1 was called core training, stage 2 was called intermediate training, and stage 3 was called higher training. Everything's in a bit of a state of flux in that the final curriculum goals for the new curriculum haven't been completely agreed and are still in review. And this is in line with what a lot of the other specialties are doing on the back of new General Medical Council guidance. But this is the basic shape of the way things will look. So stage 1 core training is basically where you're just finding your feet. And as I mentioned before, completing the initial assessment of competencies, doing a bit of obstetric anaesthesia, getting used to the theatre environment, as well as doing some intensive care. The core things Johnny's already mentioned before are looking at after the airways, critical incidents, day surgery, a bit of head and neck surgery, obstetrics, orthopedics, pediatrics, transfer medicine, trauma, a bit of everything basically, as well as gaining your basic competencies in assessing patients, managing patients in the post-operative period, and how you go about giving a general anaesthetic. So just finding your feet. Mentioned the primary FRCA before, because I think, but I think I wanted to mention it now because I think it's something that is known within medicine as being quite challenging. There is quite a broad and comprehensive syllabus. The primary is mainly focused on basic science rather than the clinical application of that. And so there is a lot of basic science to learn. So this is just a list of all the syllabus items. As I said, it's less clinical and more basic science. The basic building blocks are pharmacology, physiology, physics, clinical measurement, statistics. There are 2 bits to it. There's the FRCA primary written, which is based on multiple choice questions and single best answer questions. And then the last bit, which is the structured oral examination and the objective structured clinical examinations, the SOE and OSCE, which are sat usually on the same day. The anaesthetic exams are difficult, but not insurmountable. And as Johnny mentioned, the culture within anaesthetics is that everybody knows the exams are difficult and that we have to get through them. And everybody is very open to making it as easy as possible and supporting you to study. And there's plenty of teaching. And with one-to-one consultant supervision, you learn a lot on the job as well. Intermediate training, you do the same basic bits, so the same general duties as core training pretty much, but there's anaesthesia for more complicated things starts to come in. So for neurosurgery, neuroradiology, neurocritical care, and then as Johnny is doing at the Hammersmith, a bit of cardiothoracic anaesthesia and cardiothoracic critical care. There are also optional units in vascular surgery, ophthalmic anaesthesia, a bit of plastics and burns, if those are the things you want to do. By the completion of ST4, sorry, the completion of ST5, which is now stage 2 training, you'll have had to have passed the final FRCA. This is the second part of the fellowship of the Royal College exams. And for many, it's more straightforward than the primary. It's more clinical, so it has more focus on the actual practical anaesthetic side of things. So as you can see, there's a focus on obstetrics, ENT, orthopedics, all the things listed there. And consists of 2 parts again. So a written part, which has itself 2 parts, a constructed response question COQ paper, as well as a multiple choice question, and then an oral exam or a viva once you pass the written one, which is similar to the primary but has a more clinical basis. And then higher training is sort of preparing you to be a consultant and for complete independent practice. So the same basis of core duties and general duties, but there's more flexibility in developing a subspecialty interest with the optional units and the scope for doing fellowships in specific things within anaesthesia if you want to. So things like pain medicine, pediatric intensive care, anaesthesia in developing countries. Apparently you can do conscious sedation and dentistry, things like remote and rural anaesthesia. So that allows you to focus on the sort of things you want to be doing as part of your anaesthetic practice as a consultant. Once you've completed all that, you get your completion of certificate of training, which is a CCT, and you're now eligible for application to consultant posts. I'm conscious of the fact that it's getting quite late, so I was going to start wrapping up. Johnny mentioned that you can go for dual CCTs in intensive care medicine and pre-hospital emergency medicine, and those are both training pathways that are open to anaesthetists, but are part. There's a separate application process alongside the anaesthetic registrar posts at the registrar reapplication point. Does prolong your training, but if that's something you want to do, anaesthetics is definitely a route into that. Just want to say there's a bit of a caveat here. As I mentioned before, everything's in a bit of a state of flux because they are releasing this new curriculum. And if you are applying, I would advise you go on the Royal College of Anaesthetists website and look up the 2021 curriculum and their stated aims and goals, because it might well be something that they will think you should know for the commitment to specialty bit of the interview, because it's very topical. So in summary, we're biased, but anaesthetics is a great specialty for all the things that Johnny mentioned in terms of its variety, its day-to-day working life. We've heard a bit about what it is like to be an anaesthetic trainer or as an anaesthetist, a bit about the application process, how to get into anaesthesia, some tips and tricks, and an outline of the training program. And that's it from me. So I think we'll go over to start answering questions and answers from here. So if anybody wants to post in the chat or wants to unmute themselves and ask us questions, then I think we can answer them.
I think thanks, Andy. I just wanted to quickly mention there was only one question that came up during your talk, and that was about the weighting of the MSRA and the interview. Just to clarify, everyone, the interview, I believe, is 85% of the score, and the MSRA is 15.
Sorry, I did say 75. It's 85 and 15.
So there's a good question there about an OOP, which for everyone that doesn't know is an out of program. That's what it stands for. And there is a number of different types of OOP years. So you can have take time out of training, which you don't have to do any other training for. You can take time out of training to do research. You can take time out of training to do a fellowship abroad. And I believe there is a new OOP, which is coming out. But essentially, you can take time out. One thing that I really like about anaesthetics is once you're in the training schemes, there is a lot of support for you as a trainee, and everybody is there to support you and to get the best out of you. And although it is a big specialty, you'll realise quite quickly that you rotate through a lot of hospitals which you've had experience in, and it is a big family. So is there time during training to undertake an out-of-year programme? Absolutely. There are a number of different ways that you can do that. You can do that theoretically at any time. It's probably best to do that between your what will be your third year, so your end of your core training, and then before your registrar training. That's an opportunity to do so. But then as a formal OOP, when you're a registrar, you can take time out whenever you like. And you do that by speaking with your supervisors. And if you want to do anaesthetics abroad, that can be either as a formal fellowship, for example, and the Royal College of Anaesthetists will have lots of relationships with other places that offer those, or you can do it in anything you like. So you can just take a year out and go and work in the outback, or some remote island somewhere. So yes, there is a lot of opportunity.
I think it's probably useful to say at this point, just in terms of the general anaesthetic community being really supportive for you as a trainee, in terms of less than full-time training as well. There's a lot of scope for working as a less than full-time trainee within anaesthetics, partly because as a specialty, it lends itself to it because it's quite a sessional type basis. We work on lists and we don't have ownership over patients, so it works quite well. But there's quite a general acceptance that if you want to do it and you have a good reason to do it, then it's quite easy to organise. There are a few other questions on here. What do you think is the most difficult part of being an anaesthetics trainee? Johnny, can you think of anything?
So, I mean, it's tricky. I mean, some people say the exams are difficult. Yes, the exams do cover a large scope, but as Andy said, there's a huge amount of support for you. You get a lot of training on the job, and actually once you've done the work, you find that it's very applicable to your day-to-day life. So don't let that put you off. You do rotate around a lot. Some people don't like rotating to different hospitals. I quite enjoy it. You get to experience ways that different hospitals and different consultants do it. But no, I can't really think of many difficult, challenging aspects. I really love it, and I would really recommend it to anybody.
I was going to say the rotating around hospitals, but again, I don't find that stressful, and I can't, off the top of my head, I can't think of anything particularly difficult as such, off the top of my head. There's a question about applying for both core and ACCS anaesthetics. So yeah, the application process is exactly the same through Oriel. I believe the way it was when I applied was that when they release jobs, they release both core and anaesthetics jobs across the regions. And if you are more interested in doing the ACCS jobs, you rank those higher. And if you're more interested in doing the core training jobs, you rank those higher. And based on how you rank at interview is which job you'll get. If you solely want to do just ACCS and not core, then you could just rank the ACCS jobs. That's the way it was when I applied.
Yeah, that was the same for me. It's quite good for that, I think, because there is only the one application. Isaac, I see the question about what can current medical students do to prepare. I'm assuming that says compare for anaesthetics training. Well, I think if you go on some of the resources that Andy's shown you, particularly the ANRO website, there are lots of, and as he said, things are going through a state of flux, but there's lots of different resources on there to see how you currently score points. It's slightly different now because obviously there was a lot more weighting towards a portfolio in years gone by, but you can go on there and you can prepare, obviously, and you can imagine if you were training this year, what kind of things would get you points. So things like doing audits are always very good and useful for any speciality. Doing career tasters in anaesthetics is always very good. There are lots of different societies, and actually as a medical student, so the Intensive Care Society, for example, the Association of Anaesthetists Great Britain and Ireland, lots of these societies have cheap and sometimes free membership for medical students. So get signed up to those, and you start also picking up the lingo for anaesthetics and also what kind of things are big in the field at that time.
Yeah, and I think most medical schools, and mine was the same, don't really give you much exposure to anaesthetics as a medical student. So if there is an option to do a specialty module in anaesthetics or intensive care, that shows good commitment at an early stage as well, and something you can talk about at interviews later. And I don't know if there's a society at your medical school for anaesthesia or surgery, which is worth getting involved in as well.
Yeah, that's good. I'm just reading through the questions here. So the worst part of being an anaesthetist, I think we've kind of touched upon that. Night shifts aren't too bad. Sometimes you get a bit of a rest and then you get some days off afterwards. You also get to practice independently when you're on night shift. So we've kind of touched on rotations there. Opportunities to do audits and research. Well, depending what level you're at, of course. If you're at med school still, then of course go and speak with your consultants when you're doing your rotations. Everyone's always grateful for a keen, enthusiastic person to do audits with them. And if you're a trainee, well, then just go down to the anaesthetic department. I know it can take a bit of bravery to go down and introduce yourself, but I think most people are very receptive, especially anaesthetists, very receptive to going down and showing some enthusiasm. And normally they'll get you on board. There's always something to be done, especially around COVID times. So go down, have a chat with the consultant, maybe go to intensive care, whatever you think would be interesting, or speak with your own supervisor. You'll all have super educational and clinical supervisors. Go and have a chat with them, see if they've got any buddies in the anaesthetic department, and just go down and introduce yourself, and you never know what's going to come from just a conversation, really.
The next question is from R. What is essentially the difference between core and ACCS, and why would you choose one over the other? So the essential difference is that in the first year of ACCS, you have to do 6 months of acute medicine and 6 months of emergency medicine. Which obviously you don't do if you do the core pathway. So that's the extra year. And the other difference is that in most core training anaesthetic posts, you'll probably only do 3 months of intensive care, while you're mandated to do 6 months as part of the ACCS pathway. So you do end up doing a little bit more intensive care. So the reasons why you do one over the other, if you like the idea of having a bit of a broader based training, a bit more experience in other specialties, and are interested in pre-hospital medicine, for instance, where having some emergency medicine is useful, then doing ACCS is very beneficial, and potentially makes you more saleable as a consultant, because you've got slightly broader when you're applying for later training posts, I mean a consultant post, because you've got a slightly broader base and experience. If you want to do, you definitely want to do anaesthetics, and the idea of doing 6 months of acute medicine and 6 months of A&E is not for you, then core anaesthetics is what you want to go. That's the essential difference between the two. So I don't know if you've got anything to add to that.
No, I think that's very explained. Very well.
The only other thing I would say is, if you're thinking about doing intensive care, there is a mandatory requirement to have done some medicine post foundation for intensive care. If you've done ACCS, you have to do some medicine. If you haven't done ACCS, when you come later in life as a senior registrar in intensive care, you have to go back as an SHO and do some medicine as an SHO. At SHO level, which people don't like going back to do medicine when you're a senior anaesthetic registrar, or senior intensive care registrar. That doesn't apply if you're just doing anaesthetics. It only applies if you're doing intensive care medicine as well. That might be something that's changing with the new curriculum though, so I don't know if that's still the case. That's one other advantage for doing ACCS.
Lovely. Andy, there's some questions here about the recommended resources for the interview and the MRSA. Do you want MSRA? Do you want to touch on that, because you probably know that better than I do, mate?
In terms of specific resources, I don't want to endorse specific things. There's an IST medical interviews book for core training and specialty interviews, which I used, and gives you good ways to structure questions and answers. It's ISC. I'll put it in the chat afterwards. but there's a whole wealth of free interview guidance for medical specialties on the internet, and I think they pretty much all give you the same information. A lot of them are paid online courses though, so you should, well, I don't want to suggest one over the other really, and I haven't been on all of them, so I don't really know.
Do you mind if I interject for a plug?
Yeah.
So we're actually going to be running some practice interview stuff for free.
Okay.
At some point, if you just follow us on social media, you'll find out about it. I'd say the main point is just to practice, whether or not you decide to pay for it, just practice. Sorry, carry on.
No worries.
Thank you,
So in
Matt.
terms of the MSRA recruitment timeline, it was in my slide at the beginning. Let me just go back to it.
That for this round as well, Andy?
That should be for this round. Oh, I did have a slide. It would be in that information document on the ANRA website, but and also on the previous clinical specialty medicines essentials talk. Let me find out, and I will post it in the chat.
I just want to back up what Andy says. Those documents on the ANRA website are like gold dust. Okay, they used to do it that they'd give you the breakdowns for all the scores for interviews, for all the criteria, for everything. So before you went to the interview, or before you even did your application, you could work out how many points that you are going to score. So go on there, read them, and do everything. And that's the same for whether you are applying now or whether you're applying in 2 years' time. Get there early, read what you're getting marks for, and that will help you pick up the points. Some other questions. There's a question from Abdullah, which is specific for Andy. I don't know, Andy, if you want to speak with Abdullah about that on the side, maybe, because that's quite a specific thing.
Yeah, or I can briefly mention it here.
Okay.
So yeah, Abdullah. So it's not uncommon for ACCS acute medicine trainees to switch. It is possible to count your competencies towards CT1 anesthesia and potentially go into CT2 anesthesia, but difficult. And I don't know anybody who has managed to do that. So I went straight into CT1 anesthetics. It's quite difficult because you're on a different portfolio to transfer everything across, and the anesthetic portfolio is quite specific. So I was able to count my initial assessment of competencies, but basically I had to redo all the other assessments. So it is a bit arduous, and it is slightly unfortunate that it's difficult to progress to CT2, but theoretically it's possible, although I haven't actually heard of anybody do it.
Okie dokie. A question from ST about what we wish we knew at medical school. Well, firstly, I wish that I knew that I wanted to do anaesthetics earlier than I did, and I'm so pleased that I did choose anaesthetics and not surgery. And as I say, just check out the ANRA website for all the scoring. That's the one thing that I would say. It's all the information is there. It will tell you how to apply, how to be successful, and then you can get your ducks in order nice and early. Just about to rotate into an F1 rotation anaesthetics. Any tips for reading and experience? Well, I think you will have a great time, Zia. I wish you luck. There is lots and lots and lots of books out there. And I don't want to plug anything commercial or specific or anything, but there's a very good book that I read called How to Survive in Anaesthesia, a guide for trainees. And it's a book written by someone called Neville Robinson, who is one of the consultants at Norfolk Park. It is a brilliant book. It's succinct, it's to the point, and it's a good level if you just read through that, you know, in the evenings. As I say, anaesthetics is great for being able to read when you're in theatre. So just go into the library, and there's lots of books about there. Because it's such a postgraduate specialty, you're not expected to know everything. You know, turning up on day one, you're there to be taught, you're there to experience stuff. So I wouldn't panic that you've you don't know everything. Just go there with a positive mindset, positive attitude, and they will teach you a huge amount. And you'll practice loads of cannulas. You'll be feeling a lot more comfortable around the anaesthetized and critically unwell patient by the end of it. So enjoy.
There was a book that I used when I was starting anesthetics called, I think it was something called Introduction to Clinical Anesthesia, which was a very basic sort of introductory guide to the basic bits of area management and that sort of thing, which was very useful. If I can find a link, I'll post it in the chat. But it was a very good overview of just the not too complicated, the basic stuff you need to know.
I think, as I said, because it is such a postgraduate specialty, there are lots of resources out there. And you'll be reading the same resources as a new core trainee, because you wouldn't have done it. You may have done a couple of weeks of medical school, but nothing else. How common are the on-call shifts as a trainee and as a consultant? Well, as a trainee, that very much depends on what hospital you're at. For me, it's, well, we are 1 in, I think, 6, we're 1 in 8, and there always has to be someone on call during the day and night. So essentially you're working weekends, weekend long days 1 in 8, and weekend nights 1 in 8. So it works out as 1 in 4. And that's pretty standard, I think, from what I've seen.
My rate is the same. It's pretty much the same.
Yeah.
And then how frequent is it as a consultant? That sort of very much depends. Well, so the on-call commitments, they, not sure, they're less frequent than the trainees. And in terms of how often they have to come in for nights, for instance, is very dependent on where they work. Some centres are a lot more busy than others. So it's something to think about when you're coming to consultant jobs, about where you want to work. So for instance, at St Mary's, which is a major trauma centre, the consultants are in during their on-calls all the time, and hardly ever get home. While where I work at the moment, it's less common, if not a bit rare, for the consultants to come in at night, because the work doesn't require them to be there. So it's quite variable as a consultant.
Okay, I think we've got to the end of the questions there. I'm going to have to dash, I'm afraid. So anyone wants to ask any questions, and message Nat, and happy to answer them. All right. Thank you, everyone.